Dr. Jackson is our next speaker. I don't know if she's going to make us cry, but we'll try. No. She is an associate professor within the Division of Hematology at St. Paul's Hospital at the University of British Columbia in Vancouver, Canada. Obviously, Dr. Jackson completed her MD at the University of Calgary in 2001, and before undertaking a hematology residency, she completed a Bayer International Hemophilia Scholarship Hemostasis Fellowship at the same institution in 2009. Dr. Jackson's research interests include the that's a word that's so hard to pronounce for a French person. Okay, individualization, I make it, of prophylaxis in hemophilia, of bleeding in collagen disorders, and the impact of aging in hemophilia. She's the medical director of the British Columbia Provincial Adult Hemophilia Program at St. Paul's Hospital in Vancouver. Dr. Jackson.
Thank you, Catherine, and thank you very much for inviting me to speak after Leanne. I had to dry my eyes in time, and also to share with you some perspectives on what the future may hold for the management and delivery of care. I have a few disclosures. I think the most relevant one is that I actually have no skill whatsoever with a crystal ball, so I'm going to try my best, and I'm actually going to put you to work a little bit as well. This has been presented already in terms of the current landscape and future landscape in terms of some of the products available. I'm going to be speaking also about emicizumab or Hemlibra, although recognizing that many of the concepts are going to be applicable to other future novel therapies, especially those delivered subcutaneously. So what holds in the future? I'd like to explore this from three different viewpoints: that of how well the product treats bleeds, the patient caregiver perspective, and the health system perspective, and think about three situations. One that we've discussed already is hemophilia with inhibitors. Think about non-inhibitor situations as well as bleed-ins procedures. But before that, I want you to think about, these are just some of the things that might change in the future. I want you to think a little bit about what you think might change. So get your phones ready, because the next slide is going to be a question. I have 5 options for you to choose from. I want you to pick the least likely, in your opinion, that you think will happen. I'm hoping this will work in the voting poll. So I'll read them. So is it A, the annual bleeding rate for hemophilia A patients with inhibitors on emicizumab will be lower than the annual bleeding rate for patients with hemophilia A who don't have inhibitors on factor VIII prophylaxis? Or will it be B, patient on subcutaneous therapy will lose confidence in their IV skills? Or C, all patients with severe hemophilia will have access to prophylaxis with emicizumab or Hemlibra? Or D, the health system will measure value for patients of new therapies and stop focusing on a per unit or per milligram cost? And finally, could it be E, hemophilia clinics are downsized or closed due to less bleeds? That was provocative, hey? So least likely. Uh-oh. Okay, well, let's flip that around. Okay, so I was interested in which you had the least appetite for. Clearly, you don't think hemophilia clinics are going to be downsized or closed, which is a huge relief to me. And also, you don't have a lot of faith that the healthcare system will measure value in the future. Okay, so I'm going to go through these viewpoints and situations. It's beginning with inhibitors, and this has already largely been eloquently done for me this morning in terms of what the current situation is in product. We've talked about bypassing therapies in ITI and that they do not completely arrest bleeding in situations of inhibitors. We have an international study that showed less than 50% of Canadian patients are on prophylaxis with bypassing agents. We've heard about the burden of treatment. We know that these families dealing with ports and infections and thromboses and bleeds is an incredibly difficult journey. We also know, based on a relatively recent piece of work, that adherence levels for bypassing agent prophylaxis are actually quite low, likely due to the rigor that's required to administer them. And high adherence was estimated only in about a third of patients. These patients were over 12. And what makes the healthcare system of this? I think the healthcare system view of inhibitors is that they're a very small population, looking at around 80 to 100 patients in Canada, that cost a lot of money based on the price of the bypassing agents, not necessarily considering the price that we've heard about in terms of the impact on families and patients directly, or on hospital stays and those types of things. But when we're probably facing the first and one of the only times I can think of when a new novel product comes to license and hopefully comes to market, such as emicizumab, where the predicted cost of emicizumab is actually predicted to be a little less than the current standard of care cost. So if you do a balance based on the product cost alone, you're looking at a cost that's approximately 33% lower, just based on the price of the product when compared to the standard conventional bypassing therapy prophylaxis. And clearly and happily, we've heard that in Quebec, the Héma-Québec and the Ministry of Health have made emicizumab available just recently for patients who have inhibitors. But in Canada, and pardon me for this cartoon, but I think it's quite appropriate, what we're seeing is not yet a decision in the rest of Canada, largely because of, I think bureaucratic processes that may not appreciate the full-on impact of these products. So what can we expect in the future? I hope we can expect in the future a story for a lot of patients that mirrors what Leanne's and Jason's experience were. We clearly know that emicizumab and likely other products, as we gain more experience with them, will dramatically decrease bleeding episodes, as Dr. Bellatrudy well outlined. And we don't need a quality of life scale to show changes like we've just heard about. Quality of life will be improved. Subcutaneous treatment is different. It seems very palatable and easy. We know not a lot about the adherence from emicizumab directly, although if you look at adherence rates in chronically administered subcutaneous biologics for things like rheumatological diseases, the adherence rates are over 85%, whether it's given once a week, once every 2 weeks, or every 4 weeks. Some of the things I think we're probably going to get into later are what is the impact of this type of treatment to so dramatically reduce bleeding rates on our appetite for doing things like ITI and actually going to eradicate the inhibitor, which of course emicizumab will not do. And will we see increased use of protocols that balance the two to choose a less rigorous ITI regimen, still with the goal of eradication, and on a background of emicizumab to hopefully have no bleeding during that time? One would hope that's the direction we're going, and there's a couple of protocols ongoing I'm aware of to do that. And the health system, well, I think I can say fairly confidently that the health system is going to see decreased costs for 2 reasons. The first is the immediate decrease in costs of the product utilization, which is the whole basis of the funding. But I think there's no doubt that the health system will see decreased costs due to less joint damage, less need for joint replacement, ultimately less hospitalization, and of course less disability and more function. Just a few references. So let's talk about the next situation, which is a little bit more complicated, of the non-inhibitor patients. For hemophilia A, there's approximately 700 to 800 patients with severe hemophilia A in Canada, so a much larger group of patients. We've heard from Dr. Carcao of the standard replacement strategy, and we know that while a lot of patients are on prophylaxis, particularly in pediatric groups, there's still in adults are a lot of patients using on-demand treatment and still experiencing a residual level of bleeds that still can amount to chronic joint disease. Currently, most mild patients with hemophilia A or B are not on prophylaxis. In terms of the patient caregiver, specifically those who are using home infusions, they are best able to say that burden of treatment is still considerable in terms of the frequency of infusions, although the extended half-life products are helping with this. But they're still a residual difficulty with adherence and being able to stick to those regimens in a complicated and busy life. We know that the products require individualization to take into account factors such as pharmacokinetics, individual physical activity level, as well as the degree of joint disease. Our health system has an interesting view here that all hemophilia patients who don't have an inhibitor, for example with hemophilia A, may do a population switch to a product like emicizumab. And when you do that kind of volume-based view, you get a very different picture than what I showed you on the last slide, which is that emicizumab will cost multiple $1 million more. But we know better than to consider things just based on volume and cost. The clinics have a key role in terms of not only individualizing treatment now, but being able to advise and identify patients who stand to benefit the most. Although we struggle because the current situation of clinics in Canada is that many are drastically underfunded, and there are many clinics who don't have a full complement of the interdisciplinary team. What can we hope for in the future? Well, we hope to see emicizumab, which I'll use as the prime example, and these other treatments, including now gene therapy for the non-inhibitor group. Again, there is some data in the non-inhibitor population revealing significant bleed reductions, which was discussed. In addition, we're seeing more data to look at variations in the frequency of administration to capitalize on that long half-life of 4 weeks you heard about, anywhere from once a week. And for some patients, again, those who have therapy individualized, who can receive it up to every 4 weeks. And this is fairly exciting. Subcutaneous treatment, I don't need to talk about the adherence levels, but I think we are going to be expecting to see improved physical function in this group. And when you ask patients who've been on the emicizumab trials how many of them would want to switch back to an alternative therapy, you get a fairly high answer, as per what Dr. Coqueo mentioned, that most of them prefer emicizumab. Now, I was surprised when one of my patients spoke with me about emicizumab and voiced a concern about not treating something intravenously, so making that leap over to subcutaneous therapy, which to me seems kind of like, well, that seems so easy. But when we think about it from the patient and caregiver lens, I think we have to realize there is going to be some adaptation that needs to be taking place and some concern and anxiety around what that's going to look like. And I think that Leanne pointed that out quite eloquently in her case. At this time, we're not using prophylaxis much in mild hemophilia, but I think the availability of something like emicizumab and other subcutaneous treatments for use may push that envelope into certain patients with mild hemophilia who have a lot of bleeding, who maybe have a more severe phenotype than what their factor level alone would indicate. So this is the big question from the health system perspective. Who's going to get access to emicizumab in the non-inhibitor group? I think one of the difficulties with our healthcare system is that all the value that brought us to tears earlier in the talk that's achieved through a treatment like this is extremely difficult to measure and present to government. And I think that's our challenge as a community of patients, caregivers, clinical teams in working to generate data that will support that value and looking at a value-based framework that selects patient outcomes of relevance to patients and measures them in a large population. And if we even agree to do that, which outcomes are we going to use and how are we going to measure them? But I think if we even hope to have these treatments accessible, we're going to have to start thinking this way, because certainly our governments think very much in volume, not value. So just to finish off with bleeds and procedures, this we've talked about already, so I can whip through this. We currently use replacement therapy following well-established guidelines, and we can actually measure factor 8 or 9 levels outside of the inhibitor situation. Our patients who have severe hemophilia are experts at achieving IV access once they learn, they recognize bleeds, and they have a knowledge of their bleeding condition. And that leads to autonomy and self-sufficiency, and that's a good thing when it comes to trying to live with hemophilia. Our health system, those who have milder disease know very well, is not always equipped to have that expertise. And we see a lot less knowledge in our emergency room clinicians and in our surgical colleagues, unfortunately. And sometimes this leads to delayed or incorrect treatment. Thank you. So in the future, we know that there's some issues and specific things to know, and this has been covered by Dr. Bellatruti for emicizumab. Time has taught us that factor 7A is the preferred agent. For non-inhibitor situations, we can use factor 8, which will displace emicizumab, and there's been no concern about thrombosis or other reactions in this population. Surgical experience, as you heard, is quite early, particularly for major procedures, and more experience will be needed in order to have a good, consistent, and safe approach. There's no doubt that these treatments, especially when you're combining them with either bypassing agents or factor VIII, are going to be more technical, and a greater understanding of the interaction will be necessary. That means timely expert care involving the clinic. And some people would argue that maybe loss of intravenous skills will be an outcome of this platform of subcutaneous therapies. I think we're going to need to have more accessibility to patients and caregivers are going to need more accessibility to those health professions who know and can deal with some of the technical aspects, especially when it comes to the laboratory measurement. And other healthcare professionals require access too. And will there be an era where while at the same time patients and the health system needs this, and yet patients who are doing so well may not connect with the clinic and be seen in follow-up as frequently when they're not bleeding? So I've done my best with this crystal ball. I think that it's exciting. I think we're going to see tremendous changes like this that are monumental in terms of the landscape. Even when we think about 50 years ago, we've had tremendous change, but imagining what's going to happen in 50 years is amazing. And I'll leave you with that quote, which is not by a poignant intellectual, but maybe more appropriate to the crystal ball. And I look forward to being part of the ride. Thank you very much.